A very, very warm welcome to the second Impact webinar today on the 15th of June. We will have a deep dive into some of the implementation, science implementation research and the WASH, water, sanitation and hygiene. It gives me great pleasure to welcome Professor Matt Freeman, the Professor in Environmental Health at the Rollins School of Public Health at Emory University in Atlanta, Georgia, US. Matt looks at environmental drivers of infectious diseases, specifically access to WASH, water, sanitation, and hygiene, with a particular emphasis low middle income country. That said, he looks at the interface of WASH and the neglected tropical diseases, and he has been leading major trials in multiple settings in Africa, Asia, Mozambique, Mali, Kenya, for instance, in the African continent, India and Laos in Southeast Asia. He is also the commissioner on the Lancet Commission of Water, Sanitation and Hygiene, and he is a member of the Soil-Transmitted Helminthiasis Advisory Committee. This is all what you can read on his webpage, on the official website. Now, let me tell you also something a little bit more personal. I actually had the opportunity to meet Matt for the first time 10 years ago at the American Society of Tropical Medicine and Hygiene. And in a side meeting, he then cornered me and we had a really delightful exchange. A few weeks later, he invited me to a Gates Foundation meeting in Seattle. These were the good old times when you flew in to Seattle and there was breakfast and so forth, but also good science. And Matt was then leading a discussion to bring the WASH sector and the NTD sector together. And I tell you, the first thing was to really start talking the same language. And I very much believe this is what Matt will do today, connect now implementation science in the WASH sector. So he will give a full force presentation. Matt, we are delighted to have you here. And please, the floor is yours.
Thank you, Jörg. I just want to get a thumbs up that you can see my screen nicely. Presentation.
We see the screen. We hear you loud and clear.
Great. Well, first of all, thank you to Jörg and to Swiss TPH and to the organizers for inviting me to give this talk. You know, I often give talks about implementation science to WASH people, and this is really the first time I'm giving a WASH talk to an implementation science audience. And I thought a lot about how, you know, at what level, you know, what's the big picture here? And I think there are 2 points I want to make. One is there are, well, first I want to say why I got into this. You know, I have been doing implementation research in water, sanitation, hygiene for the control of food and waterborne infections for nearly 20 years. But for the most part, I didn't know that it was implementation science. It wasn't until, you know, 5 or so years ago that I really even learned what implementation science was. And when I heard what it was, one thing I thought was, I've been doing this all along and I didn't even realize it. And the second was, thank God there are smart people thinking about how to develop frameworks and language and approaches to answer the kinds of questions that I really care about from a public health perspective. And so I'm going to really talk about that today. How do you, this is about water and sanitation, hygiene in low-income countries, low-income settings. It's also about control of food and waterborne disease, but really I think it's about how do we have public health impact for delivering interventions that we think and we know are evidence-based, but we can't get to work in these contexts that are very challenging. You know, and so I'm going to go into that in a little more detail. And I think that the other thing that you're talking about was this kind of intersection, you know, this space between the NTD and the WASH space. And I hope that this can serve as a bridge between the kind of implementation science and the environmental health space, because environmental health doesn't neatly fit within implementation science traditionally, because the roots of implementation science really come from health service delivery. And so a lot of the methods and approaches are not totally fit for purpose for community-based delivery of environmental health interventions, or even other kinds of interventions that don't operate through the health system. And I think that's changing in implementation science, but we need more people interested in delivery outside of the health space, because that's really been the legacy of implementation science. And so so that's what I want to explore also. Like, how do we make this a bit fit for purpose for the kind of work we want to do? I'm not an trained implementation scientist. There are a lot of people who say, you have to be a card-carrying implementation scientist. Well, I'm not one of those. I'm someone who's learned about this through doing and reading. And I think it's and you have to kind of pick and choose what you want to use in many ways, because there's a lot out there. All right, so I'm gonna get started. And I think that the main thing, for just as a way to start thinking about this, this is what we think about. There's plausibility that our intervention could work if we want to reach impact. There's the efficacy of that intervention. Then there's the effectiveness in the real world. And then there's the policy and context-specific programs. So context-specific programs means adaptation. And so when we're thinking about it, plausibility, should it work, right? Should delivery of water systems, sanitation systems, improve health? Yes. John Snow told us, yes. Could it work? Well, we think it could work. It's worked in Switzerland. It's worked in the United States. We don't have large scale, we have foodborne outbreaks, but we don't have large scale, other kinds of large scale enteric outbreaks as much. Does it work? Well, not really. And I'll talk about why it hasn't really worked. And then, of course, how do you inform policy, and how do we adapt and scale? And that all gets back to, how do we make it work better? How do we do a better job of delivering these interventions? So my talk objectives, I'm going to hopefully go through three kind of components of my talk. Number one, what is water sanitation hygiene, and what are the key challenges facing this sector? Number two, how can implementation science or implementation research be applied for this control of food or waterborne disease in low and middle income countries? And finally, what do I think are the priority challenges and opportunities to WASH implementation research? And I'm going to prompt everyone for some engagement throughout. And so I hope that as we go into this first one, I'm going to prompt you for some engagement. So I'd love for you to scan this, or I'm going to put the link in the chat, and you can go to it on your computer. This is just a whiteboard, and you can see on the right side of my screen here, there's a way that you can add sticky notes. And my question at the top here, what are the interventions and impacts that we're talking about? So I'd love for you just to take a few minutes to add some sticky notes in your understanding of kind of control of food and waterborne disease. What are the interventions, and what are the impacts that we're talking about? I want us to kind of get on the same page. So feel free to throw some things up on that board. If you can't have access to that, or you're a little confused, feel free to put it in the Zoom chat. That's fine too. So what you want to do is go to this little sticky note thing on the side and just click on that. And you can add sticky notes underneath interventions and impacts. Here, I'll add some sticky notes for people to edit. So I see hand washing promotion. I see water and toilets impacts are diarrhea. Any other ideas of impacts? What are the other impacts that we're talking about here besides diarrhea? What are the other downstream elements? Great. Education. So I think that's one of the interventions people that you might think about, behavior change or some kind of education. That's another thing. Great. So latrines are there, respiratory infections, stunting. So when we think about what the interventions are, latrines are a technology, but they're not. I think a lot of people in the wash sector think latrines are an intervention, but I would say that latrines are actually a technology. The intervention is community-led total sanitation, or it's a market-based approach. So one of the things when we're thinking about implementation science is we're thinking about not just what is the technology you want people to adopt, but what's the delivery strategy? How are you actually getting people to take it up? And so it could be a hygiene, a school-based hygiene education program, indicates that it's hygiene education, but it's also about school-based delivery. Or latrines are, you want people to adopt toilets, but what you're doing is you're delivering it through some kind of community-based mechanism or through some kind of subsidy mechanism, or some kind of market-based mechanism. For water supply, maybe you're thinking, well, you want people to have water, but do you want people to have, are you delivering it through community health workers? Are you delivering it through a neighborhood level water committee, or are you doing pipe systems through the municipality? Great, so I see lots of great outcomes. Water, respiratory infection, diarrhea, helminth, gender equality, bacteria. I see water treatment as an outcome, I like that. So that's not just a health outcome, but it's an implementation outcome. Okay, and so I'm going to move on. Thank you so much. We're going to stay with this Jamboard for the next several prompts. So just some overall background. Diarrhea causes million plus deaths, mostly among young children. It's the third leading cause of death in children. All-cause diarrhea is just one part of the picture. We have cholera, we have typhoid, we have bacterial, viral, and parasitic infections that all drive all-cause diarrhea. We also diarrhea and also asymptomatic carriage. So diarrhea is the symptom, but asymptomatic carriage of infection can also lead to gut dysfunction. And that is a big factor in undernutrition. And on the right-hand side, you see of the UNICEF's framework for undernutrition, and stunting was mentioned on the Jamboard. So any undernutrition, one aspect of it is dietary intake. The other is, are you getting the absorptive capacity? And when you have early infections with Cryptosporidium and other pathogens, and you have this repeated carriage of these pathogens, even if they don't result in diarrhea, they can result in undernutrition and growth faltering. There are lots of other outcomes. Jörg and I have been involved in several of these systematic reviews and meta-analyses, not just around diarrheal disease and nutritional status, but also on lymphedema management, on steroid-transmitted helminth infection. There's Jörg right there. He also did his own one of these as well before this. Trachoma and domestic animal hygiene and diarrhea. So there are lots of different ways we can think about the outcomes related to water and sanitation hygiene. And in fact, the WHO, we have a global burden of disease, and we've looked at a lot of outcomes. So one of the challenges with water sanitation hygiene, or with enteric infections, or with water and sanitation hygiene, there's just lots of outcomes. It's not simple. There are lots of interventions. There's lots of components to the interventions. You have water, sanitation, hygiene. You have personal hygiene. You have menstrual hygiene, but also food hygiene, or environmental sanitation. Cleaning up the environment. You don't just for sanitation. You don't just have toilets, but you also have sewer systems. So there's lots of complexity on both the intervention side and also lots of complexity on the outcome side. All-cause diarrhea is not a great outcome to try to measure because there's so many things that drive it. And as someone mentioned on the Jamboard, it's not just about infectious disease, right? There's women's empowerment outcomes. There's also mental and social well-being outcomes. And the lack of focus on gender, not only in the outcome, but also in the delivery of WASH is a key problem. And this is something that I would posit as a major issue in a lot of community-based delivery in low-income settings, is we're putting more and more on women and making them do more and more things for the good of their children and being the duty bearers for a lot of these interventions. But in fact, we're burdening them by not making them systematized deliveries like in Switzerland, where you pay your water bill and you get water. We're asking women to bear the brunt of the water collection duties, treatment duties, hand washing duties, toilet duties, and that's a problem on the implementation side. So my point is, lots of complexity. Perfect perfect lens to look at implementation research, right? Because there's lots of complexity. So now on the outcome side, how do children get exposed to fecal pathogens? Well, we think about the F diagram developed in the 50s. F because just simply lots of the words begin with F in English. So fluids, fields, fingers, fomites. So feces goes from all these places into a future victim, right? And then we have some intervention strategies to address them. We have sanitation, which is a primary strategy to address sequestration of feces. We have hand washing, which is a secondary prevention strategy. Water supply improvements to help with the hand washing, water quality improvements. And then so we think that improving these things, safe water, sanitation, hygiene, can reduce diarrhea. And that's our premise. But the big caveat, 3 major trials over the past 5 years did not find an impact. And now I would say this represents about $60 million in Gates funding, these trials. Very rigorously done. The sister trials, WASH benefits, Bangladesh and Kenya, and SHINE in Zimbabwe. What we're seeing here is these are the outcomes: stunting, anemia, and diarrhea. And these are the different interventions. So WASH interventions and integrated young child feeding. And even the WASH benefits and trials, they had sanitation arms, a water arm, a hygiene arm, and a WASH arm. So they had, it was 7 arms actually in the end. And what you see here is that none of them found impact on stunting. None of them found impact on anemia. And only WASH B Bangladesh found a modest improvement, statistical difference in diarrhea. So these rigorous randomized control trials showed individual pathways and combined pathways did not have an effect. So why? All right, so there are a couple of reasons. Number one, the hypothesis could be wrong, but I would posit we don't think the hypothesis is wrong. We think if you provide sufficient amounts of environmental improvements, you are going to mitigate fecal exposure. Mitigating fecal exposure improves health. I think that probably no one on this call disagrees with that premise. Coverage. Would having more people in a community adapt these preventive measures help, because it would reduce the infection pressure from people outside. So if only Jörg gets the intervention, but everyone else on this call doesn't, and we're not on Zoom, we're actually in a village, even if Jörg does his best, he's still going to get infected. I mean, we see this with COVID, right? Everyone, you can mask yourself, but if other people aren't masking or getting vaccinated, the infection pressure is going to catch up with you eventually, right? Adherence. So that people use the thing all the time and that they do it in a sustainable way. And that could be, and I don't want to put the blame on people, again, because I don't think it's the responsibility of the householder to be responsible in this way. It's actually the responsibility of government, and it's it's the responsibility of us to deliver interventions that are appropriate for the context. So adherence is a tough word because it implies maybe people are not adhering, but in fact, it's our job as maybe the implementers or the people designing interventions to drive adherence. It's not the responsibility of the community members to adhere. They'll adhere if it makes sense for them and their lived experience. So finally, completeness. Maybe what we've delivered as WASH is actually not enough. Water supply, a toilet, and hand washing at key times is not enough because we don't typically deliver food hygiene interventions. We don't deliver systemic changes to water systems and food systems. And in the US and in Switzerland, the main outbreaks are food related. They're not related to necessarily primarily waterborne infections. All right, so let's go through each of these quickly. So coverage, higher coverage needed? And so I'm gonna give an example from one of our studies where we looked at trachoma as an outcome, and we looked at the direct effect of having a toilet, me having a toilet in my home, versus the indirect effect of everyone else in my village having a toilet. So that's the indirect effect, that's the green effect. And what you can see here is at the bottom is the coverage levels, 0 to 25% coverage, 25 to 50, 50 to 75, and 75 to 100 with the prevalence ratios. What you can see is that no real statistical differences below 50%. But once you reach 50%, you start to have overall total effects. And when you get to 75 to 100%, the indirect effect, the effect of everybody having a toilet is much higher than the effect of me having a toilet. And so one of the issues in WASH research is that we've often measured these things through direct effect. Do I have a toilet? Does it reduce my disease burden? But in fact, when people go to the bathroom, when people defecate, they defecate in the environment, they defecate in your environment. And so we need to drive coverage up. Okay, well, what's the challenge with that? Adherence. Can we drive coverage up? Do we have the tools in the WASH sector to actually improve uptake and sustained behavior change? Not really, we don't. So this is a systematic review we did looking at all the intervention studies that delivered sanitation again. And this is a forest plot. So if it's this diamond here shows a subset of these interventions. This was latrine subsidy and sanitation education drove about a 17% increase in toilet use. 17 percentage points. So from 40 to 57%, not a whole lot. And so what do we look at? When we look at the whole situation, we see 14%. So all these are different kinds of sanitation interventions: total sanitation campaign, sewerage, community-led total sanitation, sanitation education, all together a 14 percentage point increase in sanitation. So we don't have the tools. We know that coverage is important, but we don't know how to actually drive coverage, sustained coverage, high coverage in communities. And now what about completeness? Are we actually targeting all the pathways? So I showed you this F diagram. What's this F diagram missing? Another F. And that F is food, right? And food and flies. And so food and flies, I would posit, is the missing link in the WASH space. So we don't know how to deliver food-based interventions to this point. We don't have good at-scale food-based interventions. And we don't think about animals. So we've talked about humans, but we also have all this issue with animals. We have this issue with domestic animals, but we also have this issue of direct and indirect effects of animal pathogens through the food system, through the application of feces onto crops, and then also just direct effect through domestic animals. We did an analysis of the global burden of disease by pathogen. So you can see the yellow is the viruses, the blue are the bacteria, and the green are the protozoa. And the dark ones here are 28% of these pathogens can be, not necessarily are, but can be passed through animals. Represents a pretty large potential burden. And animal feces represents 4 times the amount of human feces in the world. And that's growing. So there's a lot more animal feces out there to infect people. Okay, so that's a bit about a quick move through WASH and some of the challenges of WASH, the complexity of both the outcomes that we're interested in and also the complexity of the delivery mechanism. So let's think about how could implementation science and how has it been applied for the control of food and waterborne disease? And I'm not going to go through all the frameworks, but I do want to point to a few things. So back to my slide, I'm going to really focus on number 2 and 3 here. So one, hypothesis, we think that, we do think that there's a biological plausibility that could it work? And the completeness is a little bit outside, that's another whole thing. How do we actually develop these interventions? I want to talk a little bit about coverage and adherence. We did a commentary in EHP where we talked about WASH and its many challenges. And one of the things we posit here is that WASH has sometimes felt like an intervention in search of an impact. So there's a WASH sector, there are people that deliver WASH. A lot of people that deliver WASH do it for human rights reasons. It's water and sanitation are human rights. And the governments might say it doesn't matter that they have an impact or not. What matters is that they are a human right and they need to be delivered. There's lots of other externalities around water and sanitation that aren't just infectious disease. And I agree. But I also think that we need to figure out how to maximize the control of food and waterborne disease through these set of interventions. And if these set of interventions are insufficient, then we need to rethink what WASH is and what the delivery needs to be. Because it's not okay for us to deliver ineffective and unsustainable interventions. So I talked about some of these challenges. Number one, complex innovation and implementation requirements. Very difficult, lots of context-specific challenges. Every context is different, urban, rural, poor, more poor, subsidies, no subsidies, different policies. There's limited external validity of interventions. What works in one culture may not work in another. In Bangladesh, they delivered community-led total sanitation, a full sanitation program using demand side only. It worked pretty well because there was already a sanitation market out there. When it was brought to Kenya and Ethiopia and other parts of East, Central, West Africa, it hasn't worked that well. And why? Because there isn't a sanitation market. The demand side sanitation doesn't work in the absence of the supply. And so thinking more about how we adapt these interventions to new contexts is important. I would say that there's an inconsistent development sector objectives. And part of that is this up to the top. Is it an intervention in search of an impact? The reason that different governments and different NGOs and different policymakers think about WASH is different because there's so many reasons that you could do WASH. And so there's a bit of a tension between the development sector and the health sector in the purpose even of delivering WASH. And that speaks to this idea of diverse service providers working at multiple levels, right? You have the Ministry of Health, you have the Ministry of Water, you have the Ministry of Education, but you also have the private sector. You have development NGOs. In the NTD world that many of you may be familiar with, most of these programs are delivered through the health sector. But in the WASH world, most WASH interventions are delivered through these parastatal organizations. I would say actually most of the rural delivery is through the NGOs. It's not delivered through the ministry. That's changing. I think that there's a movement away from direct service delivery, but it has been a challenge. All right. Now I want you to go back to that Google Jamboard and go flip to slide 2. I'm interested to know, based on what I've told you and what you know so far, what do you see as the key implementation challenges? So at the top of your page, there's a little arrow and you can flip to the second slide. And if that's too difficult or you don't quite understand, that's okay. Feel free to put it in the chat. And if you don't know a lot about implementation science, that's fine too. I want to talk about that next. So I see sustainability, long-term financing. The good thing about this is that it's all anonymous. So you can say whatever you want and no one will know who wrote what. I see better assessment of context. I see scale, using scale. I see cultural context, understanding multi-level contextual determinants. Yes. Educating people to understand and support interventions, right? Or not maybe just even educating them, but actually incentivizing them. I see using different evidence generation approaches. So one of those things is, we think about RCTs as the gold standard, but maybe there's other kinds of evidence that is better fit for purpose for understanding how to do this. The approach actually matches the intended outcome or desired end result. Yes, definitely. A lot of messages for beneficiaries. I think there's a two-way street here, right? Like part of it is what's the I think traditionally WASH and a lot of work in low and middle income countries has thought about knowledge as the key driver, but behavioral theory tells us knowledge isn't enough. You have to have knowledge, but you also have to have opportunity. You have to have motivation. You have to have access. You have to have incentives. So, and part of it is us thinking about how to localize or decolonize the what we're delivering. Instead of thinking, for example, well, we can prevent trachoma by just telling people trachoma is a problem. Maybe we should help people think about how to address it in a way that values their lived experience. So that's some of the behavioral pieces that we can be thinking about. And I think there are some EVOG people on the call that are the clear experts in this area in thinking about applying behavioral theory to WASH. There's only they're in an elite few set of researchers that are kind of globally recognized for that kind of work. Keeping a wide array of stakeholders advancing together. I love that. Just the idea that you need to take all the different kinds of stakeholders who are out there, this diverse stakeholder constituency, and figure out how to align activities and objectives. And I see interdisciplinary collaboration and stakeholder involvement. Great. So we're thinking about the complexity of the challenges, and we're thinking about some of how these could be addressed with implementation science. So let me quickly kind of do a little tour through implementation, what's been done, applied in Washington. I'm going to give you some examples of some of my work. So implementation science, when I was talking to the dean of my public health school about implementation science several years ago, and I said, I want to create this network. He said, well, isn't implementation science just good public health? Like, isn't it just the same, isn't it? And he said, isn't this old wine, new bottle? And I said, yeah, to some degree it is. It's in some ways it's naming and applying frameworks and consistent approaches to things that we should be doing. Smallpox eradication used implementation science. Implementation science was not a thing that was invented yet, but they used those elements of implementation research. How do you deliver the intervention effectively? So implementation science is not just the intervention, it's not knowledge generation, it's knowledge application. How do you go from, we're not trying to discover something new. What we're trying to do is say, how do you take what we know and apply it to the real world? And so it's really about impact science. And that's what's exciting to me about implementation science, is it gives you the tools to have public health impact in your work, rather than just generating knowledge for the academy, right? It's more than writing the paper. It's about making what's out there work in the real world. And so IS offers these theories and frameworks, and I think about it as a shared language. They're definitional terms. A lot of these frameworks have terms that are well defined that you can use for your formative research. You can use all the way from formative all the way to intervention to design and assessment. because the terms are well defined. Everyone's speaking the same language, so it's replicable. And so I can understand what Jörg did in his work in Cote d'Ivoire, so I could do it in Mali, because we've used the same language, the same words, and the same tools. So there, Nilsson, if you haven't seen this, if you're new to implementation science and you haven't looked at this 2015 paper by Pers Nilsson, it's a great taxonomy of the different tools. It requires a couple reads. It's pretty dense, but basically there's three main kinds of tools. There's research to practice. So how do you actually go from the knowledge that you have that you want to import into the real world to policy change, program change? The designing intervention component, and that's all the way from how do you identify behaviors and drivers? And a lot of behavioral theory just tells you that. It just tells you what are the drivers and barriers, but it doesn't actually take you all the way through. They're not action models. They don't take you all the way through to what's the intervention you need? And then evaluating. So how do you evaluate interventions and implementation in a way that isn't just a binary? It isn't just, did it work or not, which is what a lot of RCTs give you. That slide before about shine, watch, be, those are just, did it work? Yes, no. It's not why did it work or why did it not work? And so these tools allow us to ask the critical public health questions. Why and how do these things work? And I would say only through understanding why and how, not just if, but why and how, can you adapt and improve on public health delivery. So how have these been applied in WASH? Well, research or practice, rarely applied. I don't know actually of any interventions or large scale programs that have done this. Designing interventions, there's some application of theory, and I've mentioned Rana's model, which Hans Mosler developed at IAVAG, socio-ecological model, theory of planned behavior, IBM WASH. These are all great behavioral theories. And then there's some examples of using CFIR, which is the Consolidated Framework for Implementation Research, which uses not just behavioral theory, but thinks about all the actors in context. It thinks about, is your organization ready to do the work? Are your partners capacitated to do the work? Is the context right? And then COM-B, which uses behavioral theory and then takes you all the way from barrier identification all the way to, should you be doing training that includes knowledge, or should you be doing agency building, or should you be doing demonstrations? Is it about skills? Is it about opportunities? And it maps, it's fantastic because it maps the barriers and drivers to the implementation functions that you need to actually implement. And again, WASH interventions have typically been knowledge-based, and I think that's part of the challenge. Knowledge is not enough for WASH. And then evaluating, so there's been a lot of process evaluation, which probably all of you have done process evaluations, but few application of hybrid designs. And what is a hybrid design? A hybrid design is when you don't just do a parallel trial, intervention control, but you actually include implementation outcomes in there. And you might not even have a pure control. You might just have multiple ways of delivering the intervention to see which one's most effective. So I'm going to do two quick examples. One is the Chakruk-Makare intervention that we developed in Kenya with CRS and Uzima. And the second is the Andalai intervention, which we developed with Amhara Regional Health Bureau and World Bank, CIF, and 3IE in Ethiopia. All right, so Chakruk-Makare in Western Kenya, we wanted to develop a integrated behavioral behavior change messaging, low-cost intervention that integrated nutrition and WASH. And we were testing on sustained behavior. We had no health outcomes. So just looking at when we integrate WASH and early child feeding programs, could we get the behavior change we wanted? Now, here was our implementation flowchart. Now, that's very complicated. And the reason I put it up here is not so you read all the details, but so that you actually see. It was pretty complicated. The top represents all the cascade of the training and household visits of one person. They train the group. These are the neighbor women. In the standard, this is our intervention. In the standard care, it's only training, not household visits. There was multiple tools that were used for incentivization, multiple small scale technology. So we got a feeding bowl and spoon that measured, and it had the feeding bowl spoon had slots so they could measure the amount of thickness of the porridge. We had pot covers for people to use to prevent fly contamination. We used all kinds of stuff. It's very complicated, multiple levels at village level, household level. What do we find? We found really good results. We had great, I would say really surprisingly good outcomes in risk double difference. So the change in absolute percent of households adopting these behaviors. So households with the hygienic food prep area went up 21%. Percentage points. Household who stored food hygienically went up 27 percentage points, all the way down to caretakers fed more thickened food to their child. We got that up to almost 70% in the intervention. We were really happy with this, right? I think these were good, and we used COM-B for our approach. We did formative research, we designed the interventions, we designed the messaging, all based on COM-B and the CEFR framework. Okay? So I would say thumbs up to this trial. Now, on the other hand, in Ethiopia, we did a similar approach using COM-B and some other behavioral theories. We wanted to design a sanitation hygiene intervention that would target NTD-related behaviors. So we were thinking about trachoma and soil-transmitted helminth infection. So we weren't just thinking about diarrhea, but we were thinking about face washing for trachoma control and things like that. So we wanted to, but we designed it to complement the existing community-led total sanitation hygiene program of Ethiopia. We did have some health outcomes, mental well-being, but mostly behavioral outcomes. And this figure here, we had activities at Wareda level, which is the district, community level, at a group level, and at the household level. So multiple levels of intervention, but using community health workers. The previous intervention I talked about, we used our own intervention team. Here we used community health workers in Ethiopia. We broke down our behaviors of interest in sanitation, personal hygiene, and household environmental sanitation to specific practices. Those practices were driven, practices like repair your latrine whenever it's damaged. That's not typically what people in WASH think of as a behavior. We're trying to drill down on exactly what the barriers were to good sanitation. And we did that through problem tree analysis. And again, I don't expect you to be able to see what all this is. It's pretty dense, but we used, this is from theory, this is from our formative research. We had workshops where we looked at the behavior of interest, latrine use practices are poor, and the root causes, lack of capability to exclusively use a latrine, functional latrines are not available, or they're not in public places, or even to the root system, latrines are not constructed or maintained properly. So all of these boxes represent some formative data and also collaboration with local ministry people. Take home message, it was very evident, it was very rigorous, theory-driven, and complicated. And we did that for sanitation, personal hygiene, and household environmental sanitation. We used that to drive our interventions. And our interventions were not knowledge-based in the end. So we had a recognition of behavior. So face washing requires collection of more water, which is a burden. Our solution was to promote face washing by talking about how little water you needed. The benefits of the behavior, people didn't care about trachoma as much. They wanted to be beautiful. That was a driver. So we developed messages that were about people being comfortable and happy, not necessarily about trachoma. So again, not knowledge-based. We used incremental approaches. So not just saying, now build this great thing, but move your way up the ladder. Move your way up the sanitation ladder. Add things a little bit at a time. We had these goal cards, the household. It was a choose your own adventure. They could choose what they wanted to start with, how they wanted to start to improve their toilets. Okay. Again, very multi-level, engaged, theory-driven interventions. All these tools were iterated many, many times. So what do we find? This figure shows presence of drop hole covers in latrines. The black line is the intervention. The gray line is the control, baseline, midline, end line. So a 9 percentage point increase. Not a whole lot. What about the rest of the indicators that we had? I'd say basically nothing. I mean, some little things here and there, but I would say overall, this intervention did not do what we wanted. Now, why? I showed you two parallel approaches to try to target behavioral outcomes. What did we do wrong in the second one? Context. And the policy environment, we tried to deliver that intervention through the community health workers, but we failed to understand really what would drive them to do the work and failed to engage in it. And so that is an implementation issue. Substantively, we did the right things even on the implementation science side for the developing of the intervention. We used theory, we did a lot of iterative learning, but we didn't appropriately understand how these interventions could go to scale. And I would say that that first intervention, it's not scalable. I mean, it's just not, you can't take it to scale. It was done with a specific delivery modality that doesn't work. All right, so those are my examples and my personal lessons learned. So what are the priority research challenges for WASH? And I have a couple more minutes here. So I talked about these. I'm going to mention these 4 challenges, 3 and 4. So inconsistent development sector objectives and diverse service providers. Well, in our paper, we talk about this quite a bit, and that there's really important for us to think about these individual organizational systems using consolidated framework for implementation research and thinking about our implementation outcomes, not just focusing on health, but focusing on coverage, adoption, cost, and acceptability. And that's a key implementation research question, implementation science question. And the tools are there to help you think about not just what's your intervention, but what's the environment in which your intervention is being rolled out? And are you measuring the right things for the right people to get these things to scale? And then on the first set of questions, complex innovation implementation requirements and limited external validity, again, we're not trying to say what pathways are most effective at reducing diarrhea and stunting or what intervention works best. Those are questions that people might want to know, but I think those questions are false promise. What we need to know is how do we develop interventions that work? And only once we know that we can get higher coverage, higher completeness, and higher adherence, is it even worth thinking about which one works best? Because right now, none of them work. None of them work. They work to improve water access, and we should still focus on the SDGs of total coverage. But if we really want to drive gains in control of food and waterborne disease, we need to think about how to innovate on the technology and the behavior change message, and also the implementation strategies, not just training, but planning, educating, financing, structuring, quality management, and policy. We need to expand the way we think about how we deliver the interventions. We also need to focus on adaptation. So we need to have a more rigorous lens towards when a phase in which you're using the localized approach to improve and iterate on what's being delivered so that it's not cookie cutter everywhere. There has to be some level of adaptation. So I think we also need to focus on better evaluation approaches, evaluating how, not just if, an intervention works. Thinking about theory failure versus implementation failure. When it didn't work, was it because you didn't do what you said you were going to do? Or is it because your theory of failure, your theory of change was wrong? And what I mean is, it wasn't that people needed to learn more about the importance of face washing for trachoma, it's that people needed to understand how much water they needed to use. Emphasis on context. So we need to think about how to document context better and how to understand whether our interventions are contextually fit. And then research is a multi-stakeholder and demand-driven. So fostering shared ownership of research findings, improving the transfer of skills and data awareness to the people delivering the intervention, and improving data literacy, and making sure that our questions are aligned with real-world conditions. So what are actionable challenges related to design, delivery, and evaluation dissemination? So challenges: poor understanding and assessment of context, minimal application of behavioral theory, no standard approaches to document the strategy so it can be replicable, and minimal funding for implementation research. So going back to our figure here from the beginning, we want to make it work better. That's the goal of implementation research. We want to make it work better. And so along this pathway, with our poor understanding assessment of context, we need to use CEFR or other frameworks that implementation science provides for action planning, especially around who's doing the delivery and what contextual considerations are necessary. We need to apply behavioral theory. WASH has been typically, again, with the caveat that folks in EOLAG on the call, there hasn't been a lot of behavioral theory applied to WASH. And so we need to do more of that. We need to have standard reporting approaches, and we have a small project where we're actually trying to develop a consort checklist-like thing for implementation delivery for environmental interventions, so that when people are reporting the intervention, there's a shared language about what they did, so that people can understand, well, that worked in that context. What's the contextual consideration we need to think about? And then for minimal implementation, funding for implementation research, we need to figure out how to apply hybrid designs so that we're integrating not just having health outcomes, but thinking about implementation outcomes as we're doing this work. So that's my conclusion, things that I think we need to do in this sector. So I'll close there before I go to the last kind of prompt for everybody and see if there are any questions, comments, and thank everybody for your time and attention.
Thank you very much indeed, Matt, for an excellent overview of WASH implementation science. I really think you did a tour de force. Let's indeed now open for questions and answers. I see there is already one or two in the chat. So maybe Juliana and or Tekla, if you could assist, maybe we start quickly with the questions in the chat, and then let's open for just the public to post questions. We have about 25-30 minutes of time.
So Jörg, if I may, I would love to start off. And so Dr. Freeman, absolutely brilliant presentation, showing how a major public health issue is being tackled with methodological innovation. And you used several times the word impact, which I liked very much. It is truly going into the real world and wanting to have sustainable change. My question to you is, this is absolutely fascinating program of research. You did magic. How did you build the infrastructure to make that happen? Because I assume you're not a behavioral scientist, you're not an implementation scientist. So how did you build your team? How did you go about? Who did you kind of get on board? How is your research team organized in order to bring all these competencies together in order to then design these studies and execute them?
Thanks. I think, you know, there are I think there are probably two ways to do science well. One is to invent something, and you have to be really smart to do that, and I'm not that smart. The other is to borrow expertise across sectors, and so that's what I've tried to do. And I have a very multidisciplinary team at Emory and colleagues across different universities. But a lot of I'm not a qualitative researcher, but a lot of my team has expertise in qualitative and behavioral science. So I have maybe this is in the weeds, but a lot of people build a team around just PhD students, but I actually have a mix of PhD students, postdoc staff, like master's level staff, and MPH and master's students, and I build it based on a very flat structure where I bring people in for their divergent expertise and give them agency to be smart because they, I hire them because they're smart. And so, yeah, for both of these projects, I had local folks on my team. So, in Kenya, the work was run by a longtime collaborator of mine who ended up is actually at Emory after doing a fellowship at Emory, but she was, she was the manager living in Kenya, Kenyan, and she drove a lot of the work. And then similarly in Ethiopia, we had a very strong and empowered Ethiopian team that could feed up to us what the, all the main issues. And then my team from Emory was, were folks that had this diverse skill set. I don't know if that answered your question, but.
Thank you so much. Has the work you've been doing infecting other research groups in your university? Because this is something that can be applied to many, many research programs. If once you kind of commit to doing research with real-world impact, the approach you take is one which is exemplary. So has this been taken up by others, or are you, let's say, standing as a positive deviant in the system in Emory?
No, I don't think so. I think that there are a lot of, part of doing so I started this network for implementation science about 5 years ago. And part of it was just to bring together people that were already doing this work. And so there's actually a lot of strength in the silos at Emory. We have a strength in HIV, we have a strength in health service delivery, strength in cancer, implementation science for cancer. There's a lot of different nutrition, there are a lot of different areas. And so the idea was to bring people together, again, to share methodological expertise, recognizing that people were using different, applying it to different problems. And so that's been very successful, I think. And I think there are a lot of folks who are doing this, and there are people who are doing this kind of work either in areas of Atlanta that are underserved, or in areas of the world that are underserved. I will say, I think there are other universities in the US anyway, and certainly in the world, that do a better job of strategic engagement with LMIC partners. I think Emory could learn a few things from other universities that I think do this at a much higher level. But individually, there are lots of individual researchers doing this.
Great. Matt, there are a few questions already in the chat. Maybe I quickly read aloud so that you hear them and you can respond. Erica Lau asked, how do you measure the interaction interdependencies between the different levels of stakeholders?
Other two. One thing is, I'm not sure I totally understand the question, but number two, I'm not sure I know the answer. How to measure these things. Maybe a little bit more clarity from Erica, what kind do you mean during the implementation process, during the evaluation process, just during the kind of formative side? For an example, one of the tools that we use in the formative phase is outcome mapping. And we do a stakeholder, thinking about stakeholder engagement. It's very simply, you could just say, what we've done in the past is, get stakeholders together and say, who are the stakeholders and what do they do? What could they add to, what do they add to this problem? How could they be hindrances? And I think it's also important to recognize that people are people, not just the institutions they represent. So the district education officer represents his office as the district education officer, but she also has her own incentives and motivations to be involved. Maybe it's she wants promotion. Maybe it's that she wants to do, get a degree later, so she wants to be involved in research. Whatever it is, but maybe she also is territorial and she doesn't want you to do the work, so she could be a hindrance. So a little bit of that is useful just to get stakeholder. I mean, when I teach my M&E class, the first thing we talk about is stakeholder engagement. If you don't have stakeholder engagement, you're lost. I mean, we all know this, but it has to be, you have to bring people along with you. And someone said that on the Jamboard. You have to bring all these stakeholders together. We call them you're implementing partners, but also your boundary partners, people that have a stake some level in what you're doing. And so mapping that out as a first phase through, the mapping process is huge. The aspect of measuring, I don't know about measuring, but CEFR does provide some qualitative framework for measuring what they call inner setting and outer setting. So who's in and who's doing the work versus who's outside, so like in the enabling environment. And there are tools. If you go to the CEFR website, if you Google CEFR, there's the tools and the definitions of all the tools are there. There's lots of example qualitative tools that you can use and adapt for your own purposes using these kind of standard definitions. And so I hope that I addressed your question, but if I didn't, give me a follow-up.
Yeah, I think you thank you for your answer, and then your presentation is great. I think my question is like, how do you navigate, say I'm working in a healthcare setting and then so complex, and then some of the time when you're assessing the determinant at one level, and then they will tell you, okay, my barrier for not using the intervention maybe is I don't know about that, or I don't have support, or I don't have time to do that. And then in order to address that barrier, it has to go up to another level. So it's just like how you can actually flush out that complex interaction or the interdependency between different levels, so that you can accurately develop your strategies that can like address the barrier. And then most of the time that one barrier at the maybe health provider level is dependent on the maybe policy level or the higher management level. That's my main question.
I don't think that I'm expert enough to answer that question. I think it's a great question, and I wish I had an answer. If there's anyone else on the call who wants to pipe up and has some thoughts, I welcome that. From my perspective, we did these problem tree analysis that I showed in the Andalai study, and that was for community-based work, but you could do a similar mapping exercise potentially for your stakeholders, because there are lots of challenges, but the question is, what are the challenges that are the deal breakers? What are the things that actually would sink the ship? What would make it impossible to do the work? And I think that's identifying those things. And there's a lot of complexity, as you said, Erica. And the key, I think, is to try to get some good sense of what the key stumbling blocks would be, and then how to address them. But I don't have I wish I had a better answer for you, because it's such a good question.
Good, you keep thinking about that, Matt. Thank you very much. There is Marie Schneider. Marie, why don't you ask the question yourself and elaborate maybe a little bit more?
Yes. Hello, thank you very much for the great presentation. Regarding your implementation studies, I was wondering, what is the time frame or the duration, the ideal duration or time frame for such studies in your context?
Yeah, that's a great question. So these were a couple of years, both of those studies that I gave the example of. I think they didn't need to be. We spent a lot of time on the formative side. And I think knowing what we know now, we probably could have moved through some of that a little bit quicker. But I think implementation studies can be, depending on what you're trying to do, they can be pretty quick. I mean, they can be rapid, rapid trialing and testing. I think they're part of the challenge. I think is a lot of these studies get funded to be some health outcome study, right? I mean, I think most of us know that the funders typically want to fund a health impact study, but that's actually in some ways the least interesting, or it's so, I would argue that we're not in the WASH space anyway. We're not really ready to do more health impact studies. What we need to do is get tighter on our exposure, like our outcomes, not our impacts. So we need to get tighter on exposure, and we need to get tighter on implementation. And what's good about that is those can be much less expensive and much faster. And so you can have kind of iterative, the goal I think is to have iterative, let's say you have a 3-year project. You're not in the typical academic project, you might generate evidence in year 3. But what we want in these implementation studies is constant generation of evidence and application of that evidence. And so we have to push ourselves to get away from the kind of academic publishing paradigm, although it's part of our job description. But it is about applying the evidence. And even if that evidence isn't at our academic standard, being able to action on what we know. So that maybe you come back and you write up the paper later. But I think we just finished a project I didn't talk about on vaccine exemplars. So countries that were exemplars in delivery of early childhood immunization. And we did that with the Gates Ventures and the Gates Foundation. And that was a 3-year study. And we did it in 3 countries, in Zambia, Zambia, Nepal, and Senegal. Now, I think our findings are very interesting. But I think that, and it took us a long time. We did all the thematic analysis. We did all the coding and the qualitative stuff. This is looking historically at why these countries kind of had these catalytic growth in vaccine coverage. But we knew after a month or 2, the result. I mean, we knew the big buckets, and it took a little bit of time to sort through to get to the nuance. But we 85% of it after you do your if you do a good job of debriefing, you do a good job of training the local data collectors, you have good partners. We had really good partners in all those countries. You know the big picture. And I think if we want to do impact science as academics, we have to be comfortable with actioning on incomplete data. And then write the paper, dotting our I's and crossing our T's. But we can't just be so precious with our data that we have to wait 3 years. And so that's I think the dynamic. I don't know if that really answers your question, but
yes.
I think we need to aim for shorter duration projects that generate critical information earlier that values the partners. Because I think one of the main reasons UNICEF or World Bank or CARE or whoever doesn't want to work with academics is because we don't deliver on the time frame they need to do the work. And we need to get better at delivering quicker. So that's my long-winded answer to your very simple question.
Yeah, thanks a lot. Thank you very much.
But that's not easy to do. That's challenging, right?
Yes,
but it is something that gets back to Sabrina's question, actually. Sabina's question, who's on my team? And actually, a lot of the staff members on my team are not interested in doing academia. They're actually interested in program. And so it's good to have them in the academic setting, because for them, it's not about writing the paper. They just want to do the work. And so it's a lot easier for them to turn that around and say, let's just give them the information. Let's get a dashboard up. Let's get people information. So that's good. It's a little harder with a PhD student who has, they have a timeline and they want to publish the paper. So it's important for the individual incentives to think about that.
We have Jan with a question. Jan, please.
Yes, also thank you very much from my side, Jan Hattendorf from the Swiss Tropical Institute. Well, I think it's a very good idea to have also more implementation outcomes. But at the end of the day, I think measuring health outcomes or quantifying the health impact is still important. I have to say, I'm not working anymore really in the WASH sector, but 5 years ago, I had the big impression that we need better outcomes, that we have to get away from this self-reported diarrhea, that we somehow need some markers which can measure intestinal stress over a longer time, or that we need better statistical tools, because there's a good reason to assume that we have a low impact on diarrhea and a low impact on nutrition, and at the same time some impact on helminths, that this has to be combined and has to be analyzed combined to have sufficient power to also detect changes by 10 percentage points or something like this.
All great point, and I agree with everything you said. So I'm not saying we shouldn't measure health. Absolutely, we have to measure health. What I'm saying is the wash sector isn't ready to do it. The wash sector needs to get the implementation right before it makes sense for us to do another really expensive RCT. Now, that's my feeling is let's pause on, I mean, right now the money isn't there to fund that stuff, but also we're not in this sector, we're not ready for it. We have to make sure we're measuring health on interventions that achieve the implementation goals that we want. And so we need to have confidence that we can deliver interventions that meet the completeness, the adherence, and the coverage thresholds. And so that's your second point, Jan, about, or maybe your third point about statistical tools. So we are with some transmission modelers at Michigan, Joe Eisenberg's team. We have a project where we are reanalyzing the WASH benefits trials. And we're using math models to simulate those intervention results, those trial results under different conditions. And those conditions are background infection, adherence, completeness, coverage, and various other parameters that we would care about. And we've gotten some really interesting results that are hopefully going to be kind of coming out in the next few months as part of the Lancet Commission work. But in short, completeness is the thing, right? You'll never get diarrhea reductions unless you control a more complete set of pathogens through pathways. After that, coverage is very important. But completeness acts as an effect modifier for coverage. So just trying to get more sanitation isn't going to be enough if you don't have if your interventions are not completely blocking the transmission. And interestingly, the statistical, probabilistic models would, probabilistic sample size says, like, well, if you have a higher proportion of people with diarrhea, you're better powered, right? But it's actually, our models suggest the opposite, that the infection pressure, when you think about dynamics math models, the infection pressure from everyone else who isn't adhering and to the intervention, that overwhelms the system. COVID is a great example. No matter what you do, if you don't have full enough coverage, it's this classic herd immunity problem, right? So there's the infection pressure overwhelms. So it's not better to have more diarrhea. It's actually worse for your power, which is counterintuitive to how probabilistic epi would have us believe, and how we would do a sample size calculation just using probabilistic epi. So really interesting findings that I think also that fits in the context of implementation research. Modeling is a different statistical tool that helps you answer how and why, not just if. And so we need to do a better job at reanalyzing these data, using the data the data that are out there to try to answer these questions, and not be so, again, think RCTs are the only answer. And Jürg and I have done a lot of systematic reviews. And I would say we've adopted, it's a tool we've adopted from health services, right? We've adopted this from drug trials. It doesn't serve community-based delivery because there's so much messiness in the exposure and the outcome. And I think that's a problem that Cochrane, okay, I'm just about to publish a Cochrane review, but like, it's a problem that we focus on that because it's incomplete. And using some of these other statistical models, I think is definitely the way to go. So I totally agree with you. And your last point about diarrhea, diarrhea is terrible. It's very imprecise, but we have this problem in the wash space, but in other places of imprecision around our outcome, imprecision around our exposure. And we got to get tighter on that before we think about health impacts. Because what happens when you have a health impact study that shows an impact? Then you're like, well, we're going to roll that what out? What are you going to roll out? You don't know enough about what you did and what the context was to even know the application. And so it wastes a lot of money because you show that it worked in this one very tight, small community. And then now it has to go everywhere. And Jürgen and I won't even start talking about deworming and the trials that fomented like global deworming plans. We won't even go there, right, Jürgen? But it's an issue of external validity, right? When you have these highly rigorous, internally valid study designs like RCTs, and then you don't know what to do with that information because there's no external validity to what you did.
Thank you very much.
Great. Any final question from the participants?
I have a very short one. If you say wash your face, it makes you beautiful. Isn't this an ethical issue?
Why ethical? Because we shouldn't be telling people to be beautiful.
Yeah, well, because you are delivering a message for the wrong purpose.
I mean, I guess that's a question for you. Like, what people should. I don't think in the U.S. How does Unilever market their soap? I mean, how do they market? I mean, marketing is marketing. What we should care about is whether the outcome, we do no harm, and whether we achieve the outcomes we want. I don't know that we need to tell people why they should want to do something. We should figure out what makes them want to do it and promote that idea, as long as it doesn't, as long as there's do no harm. So what I would say is health messages, the evidence suggests health messages do very little. Knowledge does very little on the hygiene side. So what made people wash their hands? Okay, so what made people wash their hands during the pandemic? Probably two things. One, fear. So should we not tell people fear this? I mean, that's what drove people. The other was convenience. And that's not really a message, so that's an ethical issue. But my feeling is like the way you promote sustained hand washing post-COVID is you make the infrastructure more available. My kids wash their hands; they sanitize their hands with foam every time they go into the school now, and that'll be a lifelong practice. Should I tell them? My son's 4. Do I need to tell him wash your hands because you'll be healthy because germ theory? No, we tell them do it because I told you to. And so what? That's what they need to do. I mean, you know, I think on some level, like we want people to be aware of underlying germ theory, but at the same time, we want to meet people where they're at. And so that's my answer. I think kids are a good example. I don't think kids comprehend that. They do what their parents tell them to do, and that's good for them. So.
Good. I think we enter really interesting ground, almost philosophical questions, ethical, social, economic, and so forth. Sabina, do you have any final question? Otherwise, we would closely come to the wrap up.
We could continue for a long, long, long time, and I hope, Dr. Freeman, that will be the case when you come to Basel.
Yeah, we have to find a way. I'd love to. I'd love to. Jürgen and I'll talk offline about that.
Good.
Excellent.
So let's quickly wrap up. Matt, once again, thank you very much indeed that you were willing to jump into the cold bath. This, of course, has to do with WASH. So really, really excellent. I think the three issues that you addressed, what is WASH and what are key challenges, very, very well framed. And what I really liked is also, and this is a similar feeling I had, when you then start to discover implementation science, you actually realize this is what you have done for 20 years. And I think this is really interesting, but then with the rigor, with the theory, that you move it forward, very well done. And I also think what I liked a lot is your honesty in what you presented now. You said, is now the intervention WASH in search of impact? So you turn it around, but for me, this is also really being honest. You try as hard as possible, as rigorous as possible, but sometimes you just do not get what you really want. The why and how, I think you addressed very nicely, and this is interesting and important for a lot of the implementation science that we do. The second part, implementation science now applied to the food, waterborne diseases with a focus on low and middle income countries. Very well done. And you and your team are in a unique position because you also work in different settings. Real world evidence, but also being able to compare, share across settings, and then you realize it's the setting specificity that plays a huge role. And what I, again, like is, I mean, the scientific rigor you and your team applied, the number of publications you showed that you, the team, are involved. So also from an academic point of view, really very nicely done. On the last part, and maybe these are the three keywords I keep from this talk, the complexity, the iterative process, and how you try to apply evidence constantly in an iterative process. This is leading into this adaptive design, which I think has huge leverage, but is not sufficiently done. We have blanket approaches, be it MDA, be it WASH, but it needs this iterative process, the adaptive design. And lastly, we all want to have impact, but at one point one needs to pause. As you said, with WASH, we want to have impact, but we are basically not ready to scale it up on a global scale. Again, it needs setting specificity and so forth. So for that, Matt, if you would be with us, of course, the next thing will be to treat you with some Swiss chocolate. But this is a little bit hard through the virtual space. But we assure you, once you come to Basel, Allschwil, we treat you with chocolate on a daily basis. And then we do implementation science to see whether it has some nutritional impact. Sabina, final word to you.
So thank you so much, Dr. Freeman. We truly appreciate your example of WASH and implementation science. It was for us, I think, exemplary to see how implementation science can give push to a research program, and also of those of us who are not into your field, just feel that this is the way forward that we can pursue. And let's say, in view of the Swiss Implementation Science Network, that we can make the Swiss healthcare system and those who are doing research, not only in Switzerland, but also globally, from Swiss TPH and from EABAC, that we have an opportunity to be much more, let's say, having more societal values for the research monies we are investing. So a wholehearted thank you. Jörg, thank you so much for having chaired this session. And so I wish all of you a good morning, noon, evening, night, depending where you are.
Thank
All
you
the
so
best.
much.
Bye.